Good afternoon, everyone. Thank you for being here, and thank you for Stages for allowing me to present. To clarify, I'm not a doctor yet. I'm a third-year medical student at Temple University,
Great.
and with the help of the Department of Bariatric Surgery there, I'm going to be talking about our project, Diastolic Dysfunction Grade Decreases After Bariatric Surgery. I have no disclosures, and this is the department. So, as you all may know, or you do know, obesity is epidemic, and by 2030, more than half of American adults will be affected by obesity. And obesity affects cardiac functioning and leads to concentric remodeling and leads to left ventricular diastolic dysfunction. And this disproportionately affects African American and Hispanic populations at a higher rate, which is one of the main reasons we want to do this study. Because if you're not familiar with Temple and the Philadelphia area, Temple serves a largely minority and African American Latino population. If you see here, the light purple shaded, that's Temple's main service area, and that's North Philadelphia area, which is 83% minorities overall, with over half being African American and a quarter Latino. And additionally, 30% of families in this area with children are below the poverty line, and 20% of families without are also below the poverty line. So there's a lot of social determinants of health come into play here, and we want to see if the literature that we saw about diastolic dysfunction grades reduction after bariatric surgery would also apply to our population. So this is the grading scale we used. Or a similar one. We used a grade scale of 0 to 4 using the hemodynamic echocardiogram values, and 3 and 4 are symptomatically similar, but we termed grade 4 as non-reversible. And overall, these changes do lead to heart failure with preserved ejection fraction. Just a little background of the proposed mechanisms of how obesity leads to the diastolic dysfunction and eventually clinical heart failure. So in addition to the multifactorial changes that increase the cardiovascular risk factor burden, you have an increase in renin aldosterone activation, leading to increased plasma volumes and sodium levels, which leads to fibrosis and arterial stiffness. And this eventually leads to clinical picture of heart failure with preserved ejection fraction that we see in our patients. So the methods, our inclusion criteria, we have a database that's been ongoing in the Department of Bariatric Surgery since 2014 and has continued the past decade now. This study was done when it does results in 2023, but we keep track of every patient who comes through to undergo bariatric surgery and all their different comorbidities and what they have going on in a REDCap database. And we looked at diastolic dysfunction on preoperative echocardiograms when they're undergoing cardiac clearance for surgery. And we looked at anyone who had resulted post-operative echocardiograms, which is a little bit tough given this was a limitation that a lot of our patients can be lost to follow-up between lapses in insurance and just difficulty overall with getting to access for healthcare. But we ended up with a total of 44 patients analyzed, 9 male, 35 female, and demographically 50% African American, 4.9% Hispanics, and 9.1% Caucasian, which is in line with what we expect for our service area. And we looked at pre- and post-op comparisons of diastolic dysfunction grade, ejection fraction, and we looked at BMI just to make sure that that was a constant, that was causing the change. So for results, we did see a significant change in diastolic dysfunction grade. Preoperatively, out of our 44 patients, the average grade was 1.3, and post-op, it was 0.7, so a 0.6, just over half a grade decrease. And BMI as well did decrease significantly, which is what we would expect after ongoing bariatric surgery. And ejection fraction was not significantly changed at all. And overall, with conclusions, the average time between echocardiograms was 4 years. And this is something, future studies I think we want to look at, is potentially the effective time and just how long patients have between their pre and post-op to see what the actual effect was on decreasing the diastolic dysfunction grade. But overall, the results are promising that these changes that we saw in the literature in different populations do also apply to Temple's population with changes in diastolic dysfunction and the BMI. And for future research, besides the time effect that we'd want to look at, we want to look at specific hemodynamic variables that are used to make up the diastolic dysfunction grade scale that we used and see if we can see what specifically was decreasing and how that's significant or not significant. Thank you for your time, and I'm taking questions.